one and all for the opportunity to join you, even if remotely, and especially for the opportunity to serve as the inaugural speaker in the context of the Gross Family Memorial Lecture. Quite a family. I wanted to begin by thanking Dr. Yasman, whom I've known for some time. It would really should have been me presenting him, given what a distinguished gentleman he is. One of the pioneers of reproductive endocrinology, who started long before the name was coined, long before there were boards for reproductive endocrinology, probably long before the first fertility promoting agent was ever introduced. I was looking forward to the prospect of visiting with you all in person, and in the context of that, seeing Dr. Yasman. I regret this especially since I understand he will be retiring, which does not mean I couldn't see him the next time I come around, but this opportunity regrettably has been missed. So Marvin, thank you for everything, and enjoy your retirement. Well earned, I might add as well. 50 years of service, if I'm not mistaken. I also wanted to thank Dr. Francis for the opportunity. I think we last met when I visited a few years ago. Again, I was looking forward to renewing our acquaintance. I'm afraid this will have to wait if we want to make it happen in real time. Thank you also to Dr. Pearson, who helped throughout in planning and coordinating this effort, and the residents who have done a tremendous job so far. I know we still have 2, I believe, to go, but the quality of the presentations, I have to say, was exceptionally high, and I'm very positively impressed, and I wanted to congratulate you all for a job well done. Not just the subject matter or the content, but also the delivery. And so thank you for that extra treat, which I've been following since 8 o'clock this morning. And finally, Ms. Robin Lawrence, who has also been indispensable in coordinating this visit originally and this virtual visit more recently. As a secondary title, I coined the following. There are drivers of what we call the multiple birth epidemic in the United States. And the point I will try to make is that it is not just about IVF anymore, and that in fact it never was. Although if you ever get caught up in a social conversation about multiples, particularly in the context of fertility promotion, fingers will point almost automatically at IVF as the culprit. And that was certainly true for a while, maybe not exclusively so, but prominently so. But it's certainly no longer the case at this time. And that's part of what I would like to highlight today. The scene is changing. The relative contribution of the various culprits is changing. And I'd like to give you as broad a view as I can of what we call the multiple birth epidemic or the plural birth excess in the United States, because we certainly have many more multiples than are good for anybody. We're working on improving that, as you will see. We're making some progress, but we're hardly out of the woods in any final fashion. We provided some sort of a status report of this situation now 7 years ago in a paper we published in the New England Journal, wherein we reviewed the state of affairs at the time, although by the time the paper was published, it really related to the state of affairs as it existed in 2011. And so it's really been a good 9 years, if not a decade, since we last meaningfully reviewed this area. And we are likely going to try and publish another paper in the next year if we can. And in many ways, what I will be saying today and the slide I will be showing today are likely to make up the substance of that future report.
Dr. Adashi, I'm so sorry to interrupt. Your slides are not advancing. Can you move the selection down as you go?
I am, but I guess I'm probably on the wrong side of the screen. So we need to revisit, I think, the screen that I'm on. I'm sorry about that.
Yes, I think if you stop sharing and then re-share the screen that's on your right side, you should be fine.
Okay. So can somebody help me a little bit here with the...
So Ellie, below your slides there, you know, the presentation mode, the screen icon on the bottom right of that, of where your cursor is now, way on the bottom. Yes, if you put that up a little bit to the presentation mode.
Presentation mode. Okay.
That's correct, yes.
Yes.
Okay, now you can, if you hit your enter key or your space bar, you should be able to advance through the slides.
I am advancing, but I think they're probably viewing it on a different screen.
And that is okay with us if that's okay with you.
Looks like it's advancing now.
It is?
Yes.
Yes.
Problem solved.
Thank you.
Thank you. Okay. Sorry you missed a slide or two. Nothing critical. This is the slide I was referring to when I described the New England Journal of Medicine paper from 2013. I assume you can see it now, right?
That is correct.
Now, more recently, now almost 2 years ago, we published in the Green Journal another article which identified delayed childbearing as yet another culprit in the national plural birth excess. This was, as you will see, in some respects not a completely new observation, but that was really never mentioned before as a potential contributor to the multiple birth excess, even though we knew about this phenomenon, technically speaking, for a long time. What we didn't do is we didn't couple it to the social and demographic changes that characterize our circumstances today, wherein women increasingly delay childbearing. And so combining those two facts, the demography on the one hand, and the long-known observation that delayed childbearing actually increases plural birth, we added this additional cause, if you will, for multiple birth to the list that up to that point included IVF, of course, but also other fertility promoting agents. And there's always at the background, of course, a spontaneous component that transpires in women who are younger than 35. I'd like to begin the presentation with sharing with you the origins of the story of delayed childbearing for us, which dates back to the early 90s. The 3 years in question described the tenure of one of our fellows in reproductive endocrinology. who left us in 1994 to join his home institution, at which point he was the proud father of 3 children. Fast forward to 2012, this former fellow now invites me to speak at his home institution. He picks me up at the airport, drives me to my hotel. We stop at a coffee shop along the way. And as we begin to catch up, turns out he now is the proud father of 6 children. Now, being a reproductive endocrinologist himself, the first question I asked him was IVF involved? Or was some other form of fertility promotion involved? To which he responded with a negative. All that happened was that the couple was seeking to, what is often referred to as, quote, round up the family, end quote, have one more boy or have one more girl. But as it turned out, they had triplets. I ended up visiting with those triplets, with whom I had a wonderful chat. By then they were 12 years old. By now they're long past college. And that sort of piqued my interest and made me wonder as to what we are dealing with here. This was obviously an isolated case, but I started pursuing it at that point. It also reminded me that I must have heard about the possibility that delayed childbearing increases birth plurality before, but it sort of escaped my consciousness, and frankly, most of my colleagues were not aware of it at the time anyway. So we started searching the literature, and in fact, you can go as far back as the late 19th century. I'm showing here the title of a paper that saw press in the Edinburgh Medical Journal in 1865 by Professor Matthews Duncan, the title of which was On the Comparative Frequency of Twin Bearing in Different Pregnancies. And a quote from that paper reads, "Twin bearing increased with the mother's age." After that, we found many papers in the literature that describe this phenomenon, which for one reason or another dropped out of our collective memory. But here's, for example, a paper from the Annals of Human Genetics in 1959 by Professor Balmer, who wrote quite extensively about this. At the time, Professor Balmer was affiliated with the University of Manchester, and the paper was titled "The Effect of Parental Age, Parity, and Duration of Marriage on the Twinning Rate." The clinching figure, which is figure 1, shows in this case that the incidence of dizygotic twinning goes up as a function of age, appears to reach a peak at around age 35, and then decline in all likelihood because fertility begins to decline at that point in life. Notably, there was no change in the incidence of monozygotic twinning, which tells you that the culprit here is multiple spontaneous ovulations. In this case, the ovulation of 2 follicles releasing 2 eggs that were fertilized and gave rise to non-identical twins. And that's exactly what we suspected was going on, and certainly was the case when it comes to my former fellow. in whose case 3 follicles ovulated, 3 eggs were released, and 3 non-identical siblings were born. That brought to our mind the simple notion that delayed childbearing may well be yet another contributor to the national plural birth excess, in that we were cognizant of the social and demographic shift that was transpiring, and that clearly demonstrated that women were delaying childbearing in growing numbers, and that could potentially be yet another etiology of the national plural birth excess. I might also add, before we leave this point, that the notion of increased plurality with age was also widely documented in church records in Europe primarily, wherein every birth was recorded, particularly during a time when no contraception was available and women kept giving birth well into their late 30s. And so the notion of multiplicity as a function of age, as I said, is hardly novel, but it was sort of lost, fell by the wayside, and never connected to the social and demographic phenomenon of delayed childbearing, which is a contemporary and relatively recent phenomenon, as I will try to point out. In fact, if you try to find the term delayed childbearing in PubMed, you'll be hard-pressed to find anything until 1984. And indeed, there wasn't much going on, as you will see later from the data, in terms of delayed childbearing at that point in our history. Generally, it's been defined as unassisted birth, transpiring at or beyond 35 years of age. And as you well know, undoubtedly, it has significant health corollaries. For one, it's a little more difficult to conceive the older one gets, and gestation gets a tad more complicated with a number of established obstetrical issues that seem to rise with greater frequency in older gravidas. And so putting this all together conceptually, we said to ourselves, perhaps the US multiple birth epidemic, which we have always been interested in and concerned about, is not just about the iatrogenic forces about which we knew: in vitro fertilization, superovulation with intrauterine insemination, and I should add ovulation induction, conventional ovulation induction. It probably was not just that, because now we also have to consider demographic forces, that is to say, delayed childbearing. And combined, these iatrogenic and demographic forces give rise to the US multiple birth epidemic. In the next few slides, I'd like to tell you a few things about the dimensions of the multiple birth epidemic, the directionality thereof, and the drivers thereof, although we covered that to some degree. The term epidemic is, of course, ill-suited here, especially since we're in the midst of an infectious disease pandemic. It was never meant, of course, to connote that. It was merely meant to connote the magnitude of the problem. And that was perhaps a term first applied by Alan Templeton, who was the chair of the Department of Obstetrics and Gynecology at the University of Aberdeen in Scotland, who published in the American Journal a paper titled The Multiple Gestation Epidemic. And that's how the word stuck in a way and has since been used by many others. But to give you an idea on what we mean, perhaps we should look at some of the numbers back in 1998, which was, in hindsight, the height of the multiple birth epidemic. In 1998, 27% of twin infants born, that is to say roughly 30,000 out of a total of 111,000, were deemed iatrogenic in origin. That same year, 84% of higher order infants born, or roughly 6,400 out of 7,600, were deemed iatrogenic in origin. Perhaps even more disturbingly, in 1998, we had 627 quadruplets, even though the expectation would be, if it were merely attributable to spontaneous birth rates, we would expect 6 in the United States. And we had 79 quintuplets, which again, we would expect no more than 1 or 2 if spontaneous birth were to be involved. This, I think, was a wake-up call for the members of the discipline, including ourselves, realizing that matters were getting out of hand and that concerted efforts needed to be undertaken to rein in this problem. I might also add, by way of a thought, for those of you who are familiar with the term never event, which is used in the accreditation process of hospitals and refers to events that should never happen, such as wrong-sided surgery, or worse, wrong person surgery and the like. Those events have a great impact on the accreditation status of any hospital, and they should. And what I would like to suggest, at least for contemplation, is that in 2020, iatrogenic quadruplets or quintuplets should really be a never event. There is no reason whatsoever for this to happen, assuming responsible practice of reproductive endocrinology. Certainly not with IVF, where we control the situation by simply deciding on how many embryos to transfer. And if we use our judgment and are cautious about it all, there really ought not to occur high order multiples along these lines. The 50 years of fertility promotion, which date back to 1967, were of course a major blessing in many ways, because for once, infertility was on its way to being vanquished. Frankly, and Dr. Yesman knows this better than most, prior to 1967, we have had very little to offer to barren couples. But in 1967, the FDA approved the first ovulation-inducing drug, clomid, which has at least addressed the problem of anovulation. 3 years later, the FDA approved the first preparation of gonadotropins, so-called human menopausal gonadotropins, which allowed us to extend the range of ovulation induction to women, for example, with hypothalamic amenorrhea. And then, of course, in 1981, IVF arrived on our shores. It arrived in the UK in 1978, but it was the first baby born in the United States due to IVF in Norfolk, Virginia, was born in 1981. And so now we had ovulation induction and we had IVF. And then in 1987, the notion of superovulation with intrauterine insemination was introduced for women with unexplained infertility. That is to say, women who are ovulatory and should in principle be able to conceive, but for one reason or another are unable to do so, perhaps because of varying levels of subfertility, which could in some cases be overcome by so-called superovulation, which means the stimulation of the ovulation of more than one follicle, which is where the problem begins, and then following it after HCG triggering 48 hours later with intrauterine insemination. And then, as I said, we became increasingly cognizant of the possibility that delayed childbearing was also part of this mix, and that we ought to take that into account as well. In the next few slides, I'd like to show you something about the magnitude of the problem and its ontogeny. And so we'll discuss the national multiple birth rates from 1967 to 2017. And we'll begin by describing the curve that monitors the national twin birth rates during that interval. And as you can tell, it is a rather steep curve that has gone up over the 50 years in question, reaching a 1.9-fold overall increase, doing so at a mean growth rate of 1.7% per year, and reaching an all-time high in 2014, and really not declining meaningfully thereafter. The 2017 rate represents a tiny little non-significant decline, but that's about it. And so we remain awash in twins. So from sea to shining sea, we continue to have an overabundance of twins, and at this point, no real indication that the situation is going to reverse anytime soon, although we certainly hope that will be the case. The situation with the higher order multiples is in some ways worse, but as you can see, we are beginning to see some evidence of correction. In this case, America experienced a 6.7-fold increase in the incidence of higher order birth, which reached a high in 1998. But thereafter, we have seen a 47% decrease, essentially halving of the 1998 incidence from 1998 to 2017. And that's a significant decline, but we should not lose sight of the fact that even at that point, we are still 3.5-fold above and beyond the levels that we experienced back in 1967 before the assisted reproduction revolution. Also of note is the fact that even in 2017, we still dealt with 193 quadruplets and with 49 quintuplets. At the point where really barely, we could count, should be able to count those on one hand. But that wasn't the case in 2017. And the question is this trend moving in the right direction? And of course, in some respect, it is. We can't deny the market decline in the higher order birth rate. But at the same time, we need to keep in mind that we still got a way to go. The twins are nowhere near correcting their state of affairs. And so I would say the verdict is still out. So if we conclude these slides with a summary of 5 decades of multiples, we could say that the dimensions of the multiple birth epidemic remain substantial, and that the directionality of the epidemic suggests that it may be cresting. Twin birth rate growth may be slowing down, but hasn't gone down, and the higher order birth rate has clearly been receding. And so, as we speak today, we are looking at a mixed record, but we are also looking at a record that has yet to be fixed. Limiting ourselves now just to IVF, for which the data are only available since 1997, so 30 years worth of data. If we look at the IVF birth rates during that intervals, we can see some encouraging results. For example, we can see that the higher order births attributable to IVF have gone down 93% since 1997. Now that, at this point, means that higher order births constitute only 1% of all IVF birth. Singleton, mercifully, have increased 70% and now constitute almost 70% of all IVF birth. And 12 twins have declined 42% to make up 30% of all IVF birth. And so the news from IVF seems to be encouraging. And much of the reason for this progression is an evolution in the embryo transfer trends, which is shown here. Note that the transfer of 3 or more embryos has decreased from 83% to 4% over the 30 years in question, that the transfer of double embryo transfer has gone up, however, from 12 to 32%, although that is somewhat misleading because this is a unimodal curve that is currently on the decline. And so the movement is in the right direction. And certainly when it comes to single embryo transfers, which is really what we want, the incidence has gone up from 5 to 64%. As I will expand in the next slide, the elective single embryo transfers have gone up to 25%, and I'll explain that a little bit better in this slide here. So this slide depicts somewhat incomplete data because we do not have the last 2 years on elective single embryo transfers, specifically fresh single embryo transfers. And what we mean by that is a choice that is made by the physician and the patient to transfer electively only a single embryo, even though additional embryos are available for transfer. Under those circumstances, only a single embryo is transferred and the other embryos are frozen. That incidence, as you can see, has grown up substantially. The non-elective single embryo transfers, which are transfers wherein there is no choice, we only have one embryo to transfer, has also gone up, but there's not much we can do about this one, nor are we complaining. We do, of course, prefer to see single embryo transfers. The point to emphasize is the elective single embryo transfers, which involves active decision-making by patient and provider, and if at all possible, is, of course, the ideal outcome. Now, unfortunately, we don't just deal with IVF. And if you ask yourself, if not IVF, then who? We have the old-fashioned ovulation induction to contend with, and we have the ovarian stimulation or hyperstimulation with intrauterine insemination, which we discussed earlier. Those two constitute non-IVF varieties of assisted reproduction. Ovarian stimulation is by definition not as controlled as IVF because we can't count the number of embryos we transfer. This is all happening in vivo. And no matter how hard we try, we often get more follicles to ovulate than we mean to. This is a commonly offered procedure. At times, it can be offered as many times as 6 or more. And so the odds of something going wrong are not insignificant. This procedure is offered by generalists and reproductive endocrinologists alike, which is to say that a large number of practitioners potentially are offering this procedure, which again predisposes us to a higher incidence of multiples. And by definition, ovarian stimulation, never mind how hard we try to avoid it by ultrasound monitoring and careful hormonal monitoring, it is linked to significant birth plurality, which really cannot be helped. If we had our druthers, a case could be made for curtailing this technology. What we did try to do in this slide is to give you a sense of the quantitative relative contribution of the various actors that give rise to multiples, in this case, twins, and provide you with that information over the 30 years that correspond to the assisted reproduction era in the United States, or at least the 30 years for which data were available. And I think you can tell that IVF, although it has gone up some, now appears to be trending downward. On the other hand, OI and OS, which stands for ovulation induction and ovarian stimulation, appears to be holding its own and potentially perhaps inching upwards. And the so-called spontaneous twins is basically what's left after you subtract IVF and non-IVF technologies from the total number of twins born in the United States. The situation is a little more dynamic when it comes to higher order birth in the United States. You can tell that IVF, or the contribution of IVF to higher order birth in relative terms, is declining consistently and markedly. However, the contribution of ovulation induction and ovarian stimulation is certainly holding its own and very likely seems to be edging upwards. And so a mixed picture yet again that tends to increasingly exonerate IVF, if you will, but continue to implicate non-IVF assisted reproductive technologies. And so to conclude this series of slides, I would say that IVF does not fully account for the multiple birth epidemic in the US. Since 1997, IVF was not the leading contributor of twin infants. And since 2004, IVF was not the leading contributor of higher order infants. Which brings us to the latter part of my presentation and the delayed childbearing story. In a paper we published in the Green Journal, we showed this figure that covered the years 1949 to 1966 in the United States, which is to say before we even had Clomid, let alone IVF for superovulation. In other words, these 18 years prior to the approval of Clomid were a time when all births in the United States were spontaneous. And as you monitor, not unexpectedly, the incidence of unassisted plural birth as a function of maternal age at birth, you can tell that we have a unimodal curve for both white and Black women with some difference in the quantitative terms. Eyeballing the results for white women, it would seem that by the time white women reach age 35 or thereabouts, the incidence or the likelihood of incurring a plural birth go up by a factor of 3. In the case of Black women, it may go up by a factor of 4. The table that we constructed, which is more detailed and breaks it down by many other age groups, nevertheless, with more accurate measurements, suggests that between ages 35 to 39 in white women, the incidence of twinning goes up 2.5-fold, in Black women 2.7-fold. The incidence of higher order birth in white women goes up 4.6-fold, and in Black women 6.4-fold. Now, as you look during that same interval, that is to say prior to 1967, at the maternal age at birth as a function of the calendar year, you can see that we are looking at a steady state. Most women gave birth under 30 years of age. Fewer women gave birth between the ages of 30 and 40. And very few women gave birth over the age of 40. Remember, this is also before contraception was ever available, which means that women kept giving birth all the way through their 30s in many cases. There certainly is no indication of a trend toward delayed childbearing in either white or Black women. However, when we look at the interval between 1971 and 2016, the situation begins to change markedly somewhere in the early 80s. As you can tell, over this period of time, the number of women who give birth under the age of 30 is progressively going down, whereas the number of women who are giving birth between the ages of 30 and 40 is progressively going up. Still very few women give birth over the age of 40, and while there are some quantitative differences, the white and the Black women are qualitatively similar. When we plug these data into a paradigm that allows us to estimate the relative contribution of delayed childbearing to the national plural birth excess, we find that by 2016, delayed childbearing appears to account for 24% of the national plural birth excess, and that assisted reproduction provided the rest. That would be for white women. In Black women, as much as 38% of the national plural birth excess was attributable to delayed childbearing, the remainder being contributed by assisted reproduction. We even went as far as to carry out simulations, which of course involve a lot of assumptions and are merely an effort to look into the future without any certainty that the assumption we made are correct. But subject to these limitations, it would seem that if the current trends hold, and there's no certainty of that, by 2025, delayed childbearing in white women could account for 46% of the national plural birth excess, and in Black women for 40% of the same, which makes it a substantial element in the mix. With IVF improving, we are basically left with delayed childbearing and non-IVF assisted reproductive technologies to address the national plural birth excess. I'd like to close with just a few peeks at the future, which is really just that, and recognize what we probably already said, that the defining variables of the plural birth excess in the future are likely to be IVF, albeit probably in decreasing significance, non-IVF, which remains a serious concern, and delayed childbearing, which may well be the new kid on the block in terms of a variable that we need to take into account when it comes to multiple birth. We need to try at least to do all we can to address these three variables. When it comes to IVF, the professional societies that are responsible for this field, particularly the American Society for Reproductive Medicine and the Society for Assisted Reproductive Technology, have issued multiple practice committee guidelines. ACOG has done some of the same, all of which call for judicious decision-making in terms of the number of embryos to be transferred. There was, if you really have the time and you can actually go back and read some of these, you realize that the level of permissibility, if you will, at the beginning was quite high. I think the societies were somewhat reluctant, I think, to go on record and restrain the trade of their members. But as time went by, I think the limits on the number of embryos to be transferred became increasingly stringent. And currently, they pretty much call for the transfer of one embryo with a few exceptions, if any. When it comes to non-IVF, similar kinds of guidelines and practice committee reports were issued. Although there's really not much, unfortunately, that we can do here. Yes, we need to obviously do ultrasound monitoring and be very careful in so doing, but frankly, in the best of hands, this is at best imperfect. The only way to really constrain this variable will be to limit its use to when it's absolutely positively inevitable, which is a separate discussion, but it recognizes the fact that there is a limit to what we can do in terms of assuring that this technology is not giving rise to multiple birth, including extreme varieties of multiple birth, which are the last thing we want to see our patients cope with. There's obviously nothing we need to specifically do about delayed childbearing. It's a positive social demographic trend that we all do support and should support, although we need to educate and inform, because that issue of multiple gestation and the other obstetrical complications are realities that women who choose to defer childbearing should be aware of. And it is our job to apprise them of that. What women do with that information is, of course, entirely their decision-making process in combination with key members of their family. And it's not up to us to, in any way, modulate, modify, or interfere or intervene in this context. But it is a real phenomenon, and it is something we, as providers who care for women, need to be cognizant of, and for the women who plan their childbearing to be aware of as well. To close on a perhaps more positive note, I chose a quote from Mark Twain's baby speech in which he said, "Sufficient unto the day is one baby. As long as you are in your right mind, don't you ever pray for twins. Twins amount to a permanent riot, and there ain't any real difference between triplets and an insurrection." Mark Twain, as we looked into his history, knew something about multiple birth by way of his family. And of course, nobody could put it better than he did in this well-known speech. So with that, I will conclude. Thank you again for the privilege and the honor, and time permitting, I would be pleased, of course, to entertain any questions. Thank you very much.
Dr. Adashi, thank you so much for being with us today in this sort of untraditional platform. And thank you so much for sharing your perspectives with us. We so much appreciate it.
My pleasure.
I would like to open the virtual floor to questions. I'm checking the chat, so you're welcome to type in there or unmute yourself and ask any questions or give any comments directly. Please, anyone?
Dr. Adashi, Marvin Yasmin, would you speculate on the mechanism of spontaneous high order pregnancies in older women?
Yes, thank you. You can hear me, I assume.
Yes.
Okay. We don't obviously know, and there is no experimental information on this, but it seems reasonable to assume that as we age, the fine-tuning that is required to produce a dominant follicle, what has been known as the dominant follicle hypothesis, which requires exquisite coordination between circulating gonadotropins on the one hand and intra-ovarian factors on the other, which account for the fact that most of the time we are dealing with a single ovulation, a single egg, and therefore the likelihood of a single conception. Our best guess is that the further away you get from age 35, and certainly the further you get from age 40, those fine mechanisms which characterize our youth are beginning to fray at the edges. And what used to be a fairly dependable single ovulatory cycle is no longer that. That, of course, is just my take on it based on many years of working in this field. But there is really no direct or indirect evidence to support what I say, other than for the fact that it's a reality. Exactly how it comes about and why it comes about, I think will have to be further investigated.
Thank you.
Dr. Adashi, this is Sean Francis. I just wanted to say thank you for another tremendous presentation. And as a 52-year-old with 10-year-old twins, I can attest to the riot atmosphere and agree with Mark Twain. It's always a loss to not be able to see you in person, but it was an honor and a pleasure to have you present here for us. And I just wanted to say thank you again.
Thank you. Thank you. Really appreciate it. I wanted to say, of course, when we speak about riots, of course, it's all tongue in cheek. Twins are mighty cute. And, when you see them on those glossy magazines, they're a little hard to resist. And the same, of course, when it comes to triplets. But if you speak to any parent of multiples, the reality of waking up 3, feeding 3, dressing up 3, worrying about 3 a lifetime has a cumulative effect. And there's actually very serious literature on the impact of multiples on the family unit, the psychological impact of such. And it's not trivial, and it's certainly not non-existent. And so while we can at some level speak with jest about twins and triplets in our families, there is a serious side to it, apart from the obstetrical issues, that is more of a psychological nature that affects the marital unit, that affects depression. And there's a rich literature, in effect, on this, which, again, I don't think we generally spend too much time thinking about, because what we are generally being fed in terms of the diet that we see and read is, those cute glossy prints that fail to tell the whole story. So multiples are great and cute in a variety of ways, but there's a bunch of serious issues that I think we covered today and that you are cognizant of as providers when it comes to actually having those babies, having them safely, not just for the babies themselves, which we know have real risks of prematurity and the like, but for the mother, who, as a woman who carries multiples, is finding herself as well at increased risk. So none of this is really a laughing matter, even though we would like to ascribe to it a certain entertainment value.
Are there other questions for Dr. Adashi? Okay, we're going to go ahead and move on. Thank you so much.
My pleasure.
Our next speaker is Dr. Johnson. Dr. Bergen, would you do her introduction, please?
So it is my pleasure to introduce Dr. Sierra Johnson, who comes to us from Oklahoma, where she completed her undergraduate and medical school training. And she is going to present to us on intimate partner violence and how we can do a better job of addressing